I will now review the different ways in which the excimer laser is used to correct your vision. There are two locations on the cornea that these treatments can be delivered to achieve their effect: on the surface or under a flap. Each treatment is based on many factors, along with that individual patient's prescription. Based on your history and the eye measurements obtained, we will be able to recommend whether reshaping the cornea on the surface or under a flap would be the best option for you. The original procedures approved by the FDA were performed on the surface of the eye and were called PRK, or photorefractive keratectomy. During PRK, the surface layer, or epithelium, is removed prior to treating with the laser. Several new variants of PRK, known as epi-LASIK or LASIK, differ only in their attempt to preserve the epithelium that is reflected back before the treatment. The laser treatment is then delivered to the exposed corneal surface, and the epithelium is repositioned at the end. For the purposes of this video, we will refer to all of these variants of surface treatment as PRK. In the early 90s, surgeons in Europe combined the accuracy of excimer laser sculpting with the comfort and rapid rehabilitation of a flap-creating procedure that originated in Colombia in the early 60s. When the laser is used to remove corneal tissue from its inner aspects after creating a flap, the procedure is called LASIK, or laser-assisted in situ keratomileusis. LASIK literally means to shape the cornea within using a laser. In this procedure, there are two steps. In the first, the eye surgeon creates a flap of corneal tissue approximately 1/3 of its overall thickness. This flap of tissue, which remains attached by a hinge, is then folded back. In the second step of LASIK, the excimer laser's cool light beam is used to gently remove the underlying tissue. Following the treatment, the flap is laid back and heals in place without the need for stitches. To illustrate the difference between these two strategies, consider the analogy of a 400-page book with 50-page thick front and back covers. In PRK, the cover of the book is first removed or folded back. The front pages of the book are in turn removed and the cover is allowed to grow back. With LASIK, the cover and the first 100 or so pages are folded back on the binding. The middle pages of the book are removed and the cover and front pages are put back in place. Both LASIK and PRK can correct nearsightedness, farsightedness, and astigmatism, and both ultimately achieve excellent results. However, for most surgeons and patients, LASIK has become the treatment of choice because it offers more rapid visual recovery than PRK, measured in hours rather than days, greater postoperative comfort, and statistically better visual outcomes. Until recently, the first step in LASIK, the creation of the flap, could only be accomplished with a bladed mechanical device called a microkeratome. It typically produced excellent results, but on rare occasions, the quality of the flap is inadequate to allow for the completion of treatment. Fortunately, an amazing laser technology called Intralase eliminates this risk and makes the first step of LASIK even safer and more precise than ever before. During the Intralase procedure, 60,000 pulses per second are delivered at a specific depth in the cornea, about 1/10 of a millimeter below the surface. Each of these pulses creates a microbubble with a byproduct of carbon dioxide and water. When close to 1 million of these bubbles are connected, a flap of incredibly precise, uniform thickness is created. There are some situations in which the use of Intralase is clearly preferable to the microkeratome in patients looking into LASIK. Because Intralase creates flaps that are thinner and smaller, it spares more of the sensory nerves in the cornea responsible for reflex tearing. This is an important consideration in patients who have been diagnosed with dry eye. Intralase also places less pressure on your eye than the microkeratome. Aside from comfort considerations, this creates greater safety for patients who are glaucoma suspects. The introduction of Intralase as a tool for refractive surgeons had another significant impact. Many patients who previously looked into LASIK were not candidates because their corneas were too thin to allow for complete correction of vision and maintain its structural stability. The tissue spared by Intralase's thinner, more accurate flaps leaves as much as 4 extra diopters of tissue for the sculpting portion of the procedure. If you were told in the past that you were not a good candidate, you may now be an excellent candidate and may want to have these measurements rechecked. Finally, although LASIK has been performed safely for years, many potential candidates have been hesitant because a blade was used to create the corneal flap. If fear has been a major obstacle to your pursuit of laser vision correction, Intralase should provide you the peace of mind needed to move forward with the procedure.